Thank you very much. Thank you very much. It's a real pleasure to be here this morning, and I'd like to thank Leo Fabri. There is a general agreement with Leo. In the so-called English-speaking session, I call him Leo. And in the Italian-speaking session, I call him Leo. So please allow me to call you Leo for the next 20 minutes, then we shift back to Leo. Good on you, Giancarlo. Okay, so what I'm going to do in the next, I promise, 15, 20 minutes, discuss with you these 3 points. The pathophysiology of the interaction between chronic inflammation and risk of thromboembolism, mainly venous thromboembolism. Then discuss with you some epidemiology data, not very many. I can anticipate not very many. And then discuss with you in one slide some potential clinical perspectives. The pathophysiology. Well, the pulmonologists and the acute care physician, they know very well that we fight every day against acidosis. And we do have a number of buffering systems that allow us to fight against acidosis. I'd like to tell you that we have a second enemy, and this enemy is called thrombin. So in every day of our life, we generated several moles of thrombin. I'm actually generating thrombin right now. I hope just a few. And these thrombin are inhibited by several inhibitors in order not me to die in the next 5 minutes, at least I hope. So we have some system that allow us to protect ourselves against the thrombin generation. And when you have a condition like inflammation and infection in particular, this balance between thrombin generation and defending ourselves against thrombin generation is very much in favor of thrombin generation. And there is the reason why you have, in many cases, the complication as venous thromboembolism, and in many other cases, arterial thromboembolism. So this is actually the pathophysiology of infection and thrombosis. We have a system of natural anticoagulants that protect ourselves against thrombosis. And when you have an inflammatory mechanism, you have inflammation, all this balance is in favor of the activation of thrombin. We actually defend ourselves with 3 mechanisms. One is antithrombin, the antithrombin system. I'm sure you know it very well. Antithrombin is the cofactor of heparin. Antithrombin is able to protect us at one of the last stage of thrombin generation. Antithrombin has been used to treat sepsis. Not very successfully, but it was tried. So this means that it must have some role or some potential role. The most important system that defends ourselves from dying on the first day after we are actually born is the protein C system. If you don't have it, you have, in many cases, following a very simple infection, you have purpura fulminans. And the baby died in the first days of their life. And the protein system allows us to also, in conjunction with the thrombomodular system, to allow our endothelium to defend himself by the aggression of this component. And finally, when some fibrin is generated, despite the action of the inhibitor, you actually have a fibrinolytic system that allows you to lyse the small traces of thrombin that are generated, fibrin that are generated. So all these mechanisms are actually documented. I promise myself not to show very complicated cartoon because I know that people outside blood coagulation, they actually hate them. I have only one, a quite busy one, but only one. And I try to summarize in the slides what has been proved in the pathophysiology of the interaction between activation of coagulation due to sepsis and inflammation and venous thromboembolism. We know that if you have an inflammation, you have an increase in platelet count. It's not uncommon to see patients with 500,000 platelets. there is a downside regulation of the natural anticoagulant system. There is anyhow an initiation of blood coagulation. All these agents produce tissue factor, the LPS, that is contained in many bacteria, is one of the most important promoting factor for coagulation. Then, as you might know, in patients with sepsis, in patients with infection, you have an increase of factor VIII. And factor VIII is a system that allows us to propagate blood coagulation from the start to the end. And as I mentioned before, we also have an impairment of fibrinolysis. So this is actually what would happen. When we are in touch with the pathogens, there are several inflammatory mediators. I'm not going to mention. Many of them have been mentioned in the previous presentation. Several interleukins and cell-p-selectin and so on. And you have these three mechanisms. First of all, you have a sort of upregulation of the procoagulant pathways, essentially due to the tissue factor contained in the monocytes. You have a downregulation of the protective system, essentially protein C, but also antithrombin 3, and finally, you have a suppression of the fibrinolytic pathway. All this has a consequence of the position of small traces of fibrin on the endothelium that hours after hours, it might have became a thrombus. Again, one single cartoon. I know some people hate this kind of stuff. Just make a comparison between the upper part of the cartoon and the part below and see, for example, the role and the position of protein C. So in other words, thank you very much. I'm not sure it works. Let me try. Must be this one? Yeah. So let's see, just show the concentration of protein C very close to the site of injury in a patient without inflammation, and see how the presence of neutrophils, actually they inhibit protein C to access the place where they're supposed to do their job. And also see the amount of circulating protein C molecule, and see how the protein C is inhibited to make its own action. So if you see here what happened, you actually have an activation on the surface of monocytes that is protected by the inhibitor and is protected by the action of thrombolysis. So in other words, there are a number of situations where pathological situations that explain you how this patient has got such a number of complications. But let's see some data about the epidemiology of the correlation between chronic inflammation and the risk of venous thromboembolism. I'm going to show you just a few examples. Not too many, not so many. And I like to show you mainly recent data coming from the last couple of years, because although this correlation has been known for a long time, essentially in the last couple of years, people concentrate on working on this correlation between infection and thrombolism, venous thromboembolism, mainly venous thromboembolism. 3 slides to make a comment with you about this study that was published in the National Journal of Kidney Epidemiology 2011 by Dr. Clayton. This is a typical cross-sectional study, case control study, if you want to call it. Cases where patient aged more than 18 years, as you see, and they had the first ever episode of venous thromboembolism. And these patients were matched with individual controls that were taken for a primary care database. So let's see the data first concerning deep vein thrombosis. So patients with DVT, they had in 4% of cases a respiratory infection in the year before the event. 4%. And in 73% of these cases, this infection was in the month that was preceding the event. In the controls, this was 2.3, and in 24% of the cases, there was an infection in the preceding month. So the 1 month odds ratio was 2.64 in favor of patient having an infection before having a DVT. Let's see now the data concerning the pulmonary embolism. And it's nice to see that in this particular population, patients with the respiratory infection that occurred in the month before the PE were excluded. in order to avoid suspicion bias, in order to avoid misdiagnosis and so on. So these patients were excluded. Even if these patients were excluded, actually 180 patients corresponding to 3.5% had the previous infection in the year before, as compared with 2.3. In other words, the 3 months odds ratio was 2.5, and as you see from the 95% confidence interval, this odds ratio was indeed statistically significant. Let's move to another study. And this study was actually published in Circulation last year, and I must say that was probably the study that opened again the scenario of the correlation between infection and venous thromboembolism. These Canadian colleagues actually took almost 400 patients, and they looked for the exposition during the 90 days before hospitalization, and they compared this exposition to hospitalization with 4 different episodes away from the episode of VTE. Well, they found that an infection was present in 52% of the patients that had the DVT. And the so-called incidence rate ratio for all infection, the general infection, was 2.9. And when these data were split in patients with and without previous hospitalization, you see that the odds ratio was 6.9 in patients with the previous hospitalization and 2.6 in patients without previous hospitalization. We are talking about something really important, really peculiar, something that I must admit we didn't know until 3 or 4 years ago. But you might be curious to know, well, how this risk ratio compare with the other well-known risk factor for venous thromboembolism and pulmonary embolism. Well, just to recall, it is 2.9 for the general infection. It is 6.9 for patients with the previous immobilization. Well, there are some risk factors that are extremely well known, extremely well accepted for venous thromboembolism. Nobody will discuss about them. But see the risk ratio. For major surgery, it's 2.8. So everybody is convinced that the main reason for getting a VTE is a previous surgery. The odds ratio was 2.8 as compared with 2.9. Immobility, 4.2. Chemotherapy. It is well known that chemotherapy for cancer is an extremely high risk factor for VTE. It's 5.7, 6.9 with the previous infection and hospitalization. And blood transfusion is very, very high, as you know. It's 9.3. So the main message coming out from this slide is that we are really talking about a risk factor that is particularly important for this patient. Well, these are data for infection, but let's discuss very quickly, just one slide, about the autoimmune disorder. These are patients with a primary or secondary diagnosis of autoimmune disorder. We are talking about 33 different diseases. And the others were brave enough to collect information about almost 500,000 of patients with this condition. It's an incredible amount of patients. But the risk for PE in the first year after admission for such a condition was 6.38%. And you see the 95% confidence interval. And you might be curious to know what kind of autoimmune condition was associated with VTE. And you see the list over here. The immune thrombocytopenic purpura, the risk is 10.79, polyarteritis, polymyositis. The so-called systemic lupus erythematosus that we know as a vascular medicine doctor, as people involved in coagulation, to be a well-known risk factor for thrombosis is actually not so high. It's not so much higher than in patients having polyarteritis nodosa. So it is something that deserves attention for all of us. But let's move to a different study. That's the last study that I will mention in terms of epidemiology. These are the data from a large registry that was originally set up in Spain, but now it is spread out in all of Europe. We are talking about a population of almost 50,000 patients. And in this study, people look for the risk factor for venous thromboembolism. In 23% of the cases, it was some degree of immobility, and this was associated with an infection in 3.5% of the cases. So it would be nice to see what actually happened in this patient. When we see the risk factor for venous thromboembolism, we know some of them, and we know that trauma is a well-known risk factor for pulmonary embolism. But it was surprising to see in this particular study that acute infection is immediately the second, accounting for 15% of the cases. And when you see the incidence of pulmonary embolism and DVT in this patient that actually had an immobilization due to an infection, you go up an incidence of PE of 53% and an incidence of isolated DVT of 47%. So I think the doubts that inflammation, that infection is related to venous thromboembolism, these doubts shouldn't exist anymore. And some of you might be interested in learning what kind of infection, what side of infection was actually present in this particular situation. Well, in many cases, it was actually a respiratory infection. And this was both for pulmonary embolism and isolated DVT, followed by, pneumonia, this part of the family, with, the urinary infection that it's quite far, it's almost less, almost 50% that respiratory infection. So, if we move to your field and we take into account pneumonia and respiratory infection in general, this seems to be a remarkable risk factor for venous thromboembolism. But what's about the outcome? We are just counting the number of patients, we're just counting for nosography, for insurance, for curiosity, or we are talking about something clinically relevant? Well, you see the outcome of this patient, and you see how 3 different outcomes, including overall death, recurrent VT, and major bleeding actually occur. You are not surprised about the increase of bleeding in major bleeding in sepsis, but it is very much the same in patients with pneumonia, in patients with respiratory disease. So we are talking something that indeed has several observations. One busy slide that I'm not going to comment on details, but just to show you that these observations were confirmed by several other observations. And there is something remarkable, and I would say quite consistent across the study. Just look the odds ratio in several studies. Really, it's difficult to go through all of them. It's always around 2. You see 2-fold, 264, 250, 3.3, 2.60. So in other words, it seems that if you have an infection, if you have a sepsis, then the incidence of VTE is almost double when compared with patients without them. And what about patients that are hospitalized for different reasons? And what's about the reason for getting a VTE in this patient? Again, we have the acute infectious disease, 1.74. Immediately after previous VTE, there is a well-known risk factor for venous thromboembolism, and even before what people is concerned about. I'm talking about cancer. So again, we are talking some consistent data across the literature. Just a few words, and I'm getting close to the end of this presentation, just a few words about the clinical perspectives. Very nice to have a document of what is going on, very nice to have some data, very nice to have some odds ratio, very nice to scare people about the risk of venous thromboembolism. Anything we can do? Well, some observation. We know that in the United States, where the data are quite reliable, we have about 3,500 patients hospitalized every year for VTE. And it's not surprising anymore that in about 50% of these patients, we have an infection that is precedes the appearance and the occurrence of this VTE. And we also know that the risk of hospitalization is almost 3 times greater within 3 months if you have an infection. But we also know from the literature that we have some options concerning prophylaxis. We know that prophylaxis can be given safely, prophylaxis is effective. And actually, if you go back to the studies where prophylaxis was tested in medical patients, we have actually 3. The risk reduction was quite remarkable, quite consistent across the study, was 50%. And if you go inside these studies, you will not be surprised anymore to see that the prophylaxis was effectively mostly in patients with infection. So it's not so surprising anymore. These studies were done 10 years ago, and at that time was a surprise. I mean, most of the effect is actually seen in patients with sepsis, with infection. I don't believe it's so surprising anymore. Now we have a biological rationale that will explain why this is the case. So this is my last slide. I think we can now say that acute infection and the inflammation that is associated with acute infection may increase the risk of VTE. We do have several demonstrations about this issue. Concerning the site of the infection, and I think this is particularly important in this particular setting, the setting we are discussing today, in most of the cases we are talking about respiratory infection because they do account for the large majority of VTE episodes, of the so-called infection-associated VTE. And finally, as the last point, I'd like to mention that we do have now data showing that you can actually prevent VTE in patients with infection. So I'm not able to now to elucidate the potential design of a study on prevention of VTE when prophylaxis should be done, but certainly it is something that we should take into account. Thank you very much for your attention.
Thank you very much for your very impressive presentation. There is one question.
Very nice presentation, thanks. What type of infection? Is there any cutoff of severity? I mean, a common cold infection or a flu infection, would it be sufficient to activate the system?
Well, in the evaluation of the association between the two phenomena, several studies were done. And it was established in binomial way, yes or no. But it was also, in other words, studied in terms of linearity of the severity of disease. Certainly pneumonia with respiratory failure is the number one, and with some surprise, the infection of the urinary tract was less important. Whether it's simple, let's say, sore throat would have been the reason for that is potentially unknown. And the reason for that is that most of the data actually come from, let's say, the huge registry of public health. And usually this kind of condition are not reported. So if I can answer your question, I wouldn't say not properly, but with some approximation to the truth. I mean, the conditions that are associated with are those that are currently reported in the big register of public health, Danish public health, Scandinavian, US. So whether it is a small, simple infection is difficult to answer.
The last one.
My question was a little bit, or a lot like what Papi have asked you, because in this case it's about infection. I'm sure that there were many other comorbidities, if you want, to the infection. And I wonder if a multivariate analysis had been done, because obviously we cannot treat everybody with a pneumonia, but are there any other?
Well, of course, it's a very good question. I would say it's a basic question for the epidemiologists. In the main paper, certainly in the first paper I mentioned, that was published in the National Journal of Clinical Epidemiology, all the data were adjusted for several covariates. And the odds ratio was still there. In some cases, it was even higher. So my tentative answer to your question is yes, it will remain after adjustment.
Can I have a very short question, just following the question by Cosio? Among the factors that may have been linked to the risk of pulmonary embolism following infection, is there any link with aging process? I mean, maybe aging is, of course, an important factor for atherosclerosis per se, but is there any reasonable reason for which this dimension could be linked to the risk of pulmonary embolism after infection, several hospital infection?
Yeah, the answer is probably yes. Of course, I mean, I like to my answer would be yes. Tentatively will be yes. but the type of question I am receiving, I think I should be a little bit more cautious, and maybe I gave a message of, let's say, definite, the end of the story. This is just the beginning. So I like to say probably yes, but I like to say we are beginning, starting about infection as a risk factor. It's quite surprising that up to a couple of years ago this was not the case, and we need to start different. And there are now some risk scale for VT that included infection, and surprising enough, this was not true until 2009.
A partial reason for my question could be that when you talk about the prevention, maybe this could be one of the reasons why you can imagine how to deal with prevention at different ages and with different possible risks for that.
Well, as I said, it's going to be difficult to plan a study on prevention. It's quite easy to make a prevention study in the hospital. Patient already there. Think about a plan in the community. It's going to be extremely complicated.
Yeah,
so it's something that I mentioned. I mean, it's going to be very difficult to design. But I think that the main message of my presentation today was to provide you with some data. I think very good data showing a new association. Whether this will have a clinical implication, I think it will be. But of course, we need to.
Thank you very much.
We have to move on. Thank you very much indeed again.